Hi, everyone. So I'm going to talk about staffing in the neurointerventional suite, which I think that for all of these topics, there's probably the least literature on this one. And I think we're in the learning phase at this point. So here are my objectives. I have no disclosures. So there is a paper that was done by SVIN colleagues and talking about how to approach setting up a neurointerventional suite, which is something that I have recently been tasked to do. So, and there's a lot of things that you can't really fake, you can't go over. You need the machinery, right? You need the methods sought out and put into your clinical practice guidelines. You need to have metrics that you're following and that you'll report to DNV or Joint Commission or whoever is monitoring your lab and how you function and what your door in and door out times are. And the materials, of course, you need to staff the lab, but you also need to stock the lab so that you have everything that you need for all kinds of procedures that you're going to be doing. And largely this depends on your physician staffing and what procedures they can actually do and who comes into your BiPlane suite and you know what procedures they're comfortable with. But what I want to focus on is that first M there, the manpower. So I don't know if any of you are familiar with Flat Stanley books, but so if you're not familiar, Flat Stanley is a character who, it's a children's book. He got squished somehow, I forget, something with his brother. But anyway, he's squished, and then he starts to take trips because he's squished so he can be sent through the mail. And it became this big thing that they do this with all the children now, and they have Flat Stanley projects in the 2nd grade. So my son made his Flat Anthony, and I forgot about this, being the wonderful procrastinating mother that I am, until the day it was due. So I freaked out, and I was like, we can't send Flat Anthony to any of our family members because I don't have time for that. So I took Flat Anthony to the NI suite, and that was his trip. So in doing that, I actually got to see exactly how many people a patient is actually touched by when they go through this process, because I had so many people come up to me and be like, what the hell are you doing? I'm like, well, I have to do this project, so would you pose with my flat for me? And I'm going to take a picture with you. So I did that. And actually, the class loved it. They thought it was really cool that, you know, Flat Anthony got to go to the angio suite or to the hospital. They didn't know the difference, but so we learned a lot about, you know, what the patient sees and what the patient goes through in an outpatient and an inpatient setting going through a neurointerventional suite. So there are a lot of different models, and the model that your hospital has and the location of where the angio suite is, or the biplane is, will largely determine what your staffing looks like. So, you know, mostly we worry about, is it tech-heavy staffing, is it nurse-heavy staffing, or is it a perfect combination of the two? And what is the perfect combination of the two? But the responsibilities need to be clear before you think about staffing these suites. So what are we actually responsible for during a procedure? We're responsible for hemodynamic monitoring, and that can be, you know, anywhere from just taking blood pressure and monitoring heart rhythm to having a flow track, or you have a patient that's, you know, hooked up to an EVD. You know, so there's a lot of different modalities of monitoring that different suites have. And then medication administration, neurological monitoring, and a lot of these patients are awake during procedures. And then, you know, you have certain suites where you have fellows, or you have techs, or you have nurses that are scrubbing and actually being the operator assistant, managing the equipment, getting the things off the shelves, running to the cath lab or the cardiac lab sometimes when you don't have that stent that you need, and radiation management, of course, and then all the documentation that comes with it. I would say most labs that are not in a cardiac cath lab do not have a MAC lab, and their regulations for what needs to be on that documentation, a lot of it is put on the physician, and not so much as, okay, I'm in this vessel at this moment, and writing every single minute down. So a lot of it comes on to the nurses, especially for that kind of documentation. And what do the nurses need to have? So when you write up your clinical practice guidelines and you have a review for a thrombectomy capable or a comprehensive center, they'll ask, of course, what you require of your nurses that are in these types of suites, and your APPs that are in these types of suites. And usually you can get away with, okay, we require them to all have NIHSS, we require them to all have ENLS. Some of them are certified, some of them are not, but usually they'll have that same sort of background on paper that an ICU nurse would have. They have their PALS, they have their ACLS, they have their BLS, sedation administration, and then there's the specialty areas, that hyperosmolar therapy. Do they know what they're doing in that case? Because those are really neurocritical care skills. Proficiency in ICP management, again, neurocritical care skill. And anything else that is specific to that unit, which could be different depending on the unit, and I'll talk about that in a minute. So what else are we responsible for, not just in the suite, but around the whole procedural area? Responsible for intake and assessment, which is really important because you have a lot of patients coming into this suite as an outpatient, a lot of them elective procedures. So your intake and assessment is really important in that you might be the first line person as an APP or a nurse that is seeing that patient when they come in to get brain surgery. An organization of the services and procedural schedule. Who better to do the schedule and organize the day than the people who are having to run around and go through room to room or CAT scan to room and function in all of these areas. Patient and family education. We have patients that come in for a 45-minute procedure. They see the doctor during the procedure, and then the doctor is gone, and the procedure was to implant a link device or something like that. And then, they're given the device, and we send them on their way. And then it's up to your staff in the suite or whoever's recovering to really make sure the patient knows what they're doing when they get home with that device. And they, would have to be savvy on what these devices are and what they do and how to monitor and who to call and when to call. So the education portion, is pretty heavy on the nursing staff usually. And staff training and education. So when it comes to thinking about who you want in your angio suite, you have to think about what the levels of education are for each person and how you're going to nurture them to come up to be one of those senior people. And now it's difficult because we don't have that many very senior neurointerventional nurses. We have people who've worked in cath labs for years. We have people who worked in IR suites for many, many years. But for neuro, their knowledge is relatively new. And coming up with standardized programs that you can put every person, every nurse, every tech through as they come through the process, and make sure that they're all on the same level to the degree where you can say, okay, at 3 months you're trained, at 6 months you're trained, and we know that. And have them involved in the performance improvement. Keep the training going so that they understand that they are part of a team and a part of a much larger picture. And if they are not involved in your performance improvements efforts, then they don't get invested into that portion of it. So your location of the biplane will largely affect your staffing. There are several hospitals that have their biplane in their OR, and they have their physicians as surgeons. So the staffing in those areas are a world of difference between the staffing in, let's say, an IR suite. your technologist staffing in that area don't usually have all of this background of IR. So you know, when you're thinking about setting up a biplane in an OR, you have to think about bringing in staff from other areas and at least training the staff that you have to be comfortable in a procedural area that includes radiation. And I think that, in my opinion, the OR staffing tends to be a little bit more nurse heavy for biplane suites. And then your presence of anesthesia. It's much easier to get anesthesia into an OR. Getting anesthesia into an IR suite, getting anesthesia into a cath lab is much more difficult. The cardiac cath labs are usually tech heavy, and a lot of people who know procedures really, really well. A lot of people who know hemodynamic monitoring really, really well. But when you first start doing neuro procedures in a place like that, when you talk about the carotids up, a lot of people are not very comfortable. So it takes a lot of training, and it takes implementation of that neuro focus and the neuro assessment, because they're not used to having that level of assessment that they need to do, especially while the patient is awake. And then interventional radiology, this I think is where you get the most wide variety of staffing and of physicians that are doing the actual procedures. Oh, I don't know what happened there, but that was my picture of my flat in the actual angio suite with two of the surgeons there. But yeah, he's under there. He actually got to go in and have a procedure. So anesthesia. I just want to talk a little bit about the challenges with anesthesia, because I think the biggest challenge with anesthesia is timing and the fact that you actually have to direct them what to do. So we don't typically intubate all of our patients. We don't put them under general anesthesia for all procedures. There are some places that I've heard of that are doing, are intubating every stroke patient and putting them under for these procedures, which is crazy, and it takes too much time. And there are places that, barely give Versed and fentanyl and, before they're puncturing. So if you have anesthesia on all the time, that's wonderful. But if there's someone who needs to be called in for these types of procedures, is it worth it to have anesthesia there for an acute procedure? What are they adding to your, what value are they adding to the room? And that largely depends on your nursing staff. Do you have the nursing staff that can cover what an anesthesiologist does during an acute stroke? And what about an aneurysm? If you're coiling an aneurysm, yes, your patient is intubated, they're sedated, but now your anesthesiologist is in charge of that portion of it, and what does your nurse do at that point? How many nurses do you need in the room? Should your staffing be different when you have a patient who's intubated under anesthesia compared to when you have a patient who is awake and needs constant neurological monitoring, hemodynamic monitoring, documentation, medication administration? So the nurse in the room is where you get the breadth of knowledge from different areas, and that's also where you get the most room to actually adjust your staffing accordingly. So when you want to build the correct team, you want, and this is all now my opinions, so building the correct team means to have enough staff that you can play around with the staffing per procedure. You need to have enough experience in that room. And if I was going through this, this area and I was about to have a procedure, I want the most experienced people there, right? But what does that experience mean for nursing? For techs, we understand what they need to be competent in. For the physicians, we have regulations on what they need to be competent in. What does it mean for a nurse to be competent in the NI suite? Because you have procedural competent nurses that know catheters, they know the procedure end of it. We have nurses who are excellent in hemodynamic monitoring. What does a nurse look like who is super proficient in an NI suite? And I would say you have to pull from every area. I would put one nurse that maybe is from a procedural area, cath lab, and put them there. I would take one nurse from neurocritical care and say, okay, we can teach you the technical stuff, you're here. I would take one nurse from maybe an emergency department or something that they are used to getting people in and out fast. And they can do this without blinking an eye, and they can kind of coach the rest of the team when something goes wrong. So I think that is your best nursing staffing, is to have all areas of those kind of experiences of nurses to teach each other and have them work off of each other so that they can teach the newest staff that's going to come up and get trained in these areas. And for technologists, I would say the best technologists and the best managers of the technologists are people who can adapt and are people who enjoy teaching and enjoy mentoring. You cannot have a technologist staff of people who just say, I know what I'm doing, leave me alone. They need to teach, and they don't just need to teach each other, they need to teach the nurses, and they need to teach the fellows and the trainees that are coming up. And we need to have effective managers. So what does a manager look like in the NI suite? Of course, the best nursing manager would have experience in all of these areas, right? But I think it's very important for them to have neuro background, especially if they have the opportunity to work in a suite that only does neuro. And then work in conjunction with the technologist manager. You're a nurse, you're a nursing manager. You should not be in charge of the technologists as well. They have their own field, and they have their own expertise, and they have their own competencies, and it's important that we let them manage each other. And then our second operator. Our second operator can look very different from one hospital to another. It could be, of course, the trainees, your fellows, an RN first assist or an APP. Or a lead technologist that is there as the right hand of the operator. And then your post-recovery units. So these staffing all look very different. All post-procedure looks very different in every hospital. So you need to decide what is most important in each area that you have. A lot of these patients go to PACU right away. A lot of them go to ICU right away. There's IR recovery areas in certain hospitals. Some recover in the cath lab. So depending on the area, of course, there's going to be a lot of diversity as to what the staffing there looks like. But what's important, especially as stroke people and if any of you are stroke coordinators, is to monitor their education. Monitor the education in those areas to make sure that they are proficient at knowing what the procedure was and what potential you have for post-procedural problems. So this is my ideal nursing team that I was talking about: an emergency, critical care, neurocritical care, cath lab, pre-hospital if possible. So you do have those rare nurses that have that interfacility or pre-hospital experience, and I think that experience is invaluable when you're talking about getting a patient on the table in the manner that you would do for a cath lab. Quick, sometimes it's a quick and dirty method. And then interventional radiology and operating room. That's it. All right. Any questions?